Hello, and welcome to Chapter 5. We will discuss confusion, dementia, and Alzheimer's disease. What I want you to know and understand that throughout your career as a nursing assistant and even as you progress to other positions in healthcare, you will always work with residents and patients who will experience confusion, have a history of dementia and Alzheimer's disease. So in this chapter, we're going to talk about each one of these disorders and what is your role as a nursing assistant. Keep in mind, we talked about some characteristics of a good nursing assistant. You must be compassionate. You must show empathy and sympathy towards your resident. Understand, put yourself in their situation and try to understand the reason behind the behavior. And in order to effectively work with someone who are having these types of actions or expressions, it's going to take positive attitude, which we talked about. It's going to take approach, and it's also going to take a lot of patience. And then your actions, how you actually respond, is going to determine the outcome of your day. So let's take a look here at chapter 5 here. What is confusion? Confusion is the inability to think logically and clearly. So think about now in your most normal state, you're able to think clearly, you're able to reason, you're able to understand, but just imagine the opposite. You're unable to think logically and clearly. So imagine how that will make you feel if your thoughts were not clear. And then we'll also shortly talk about delirium, which is a state of severe confusion that occurs suddenly, but it is usually temporary. So here are some points to remember about confusion. It interferes with ability to make decisions. Your personality may change. Anger, depression, and irritability are other signs trying to cope with the fact that you cannot think clearly, and it can be a temporary issue or it could be permanent. Now, what are some of the common causes of confusion? And so let's talk about that. In chapter 4, we're going to navigate through the different body systems as well as the conditions, infections, and all of those things related to health. But here are just some of the things that can cause confusion, whether it's an elderly person, a younger person. These are some of the reasons why someone could be confused. A urinary tract infection, which is a buildup of infection or bacteria that could possibly enter into the bloodstream and cause confusion. Low blood sugar, which we learned in chapter 2, hypoglycemia, can cause confusion. Head trauma or injury, dehydration, nutritional problems, fever, a sudden drop in body temperature, lack of oxygen. That is very important because what we're going to also learn is that we're going to take someone's oxygen levels. We're going to measure it by using a device. You'll learn that in chapter 7 to determine if they do have low oxygen or lack of oxygen. Medications can also cause confusion. Infections, that is very important. Any type of infection can cause confusion. A brain tumor, any type of disease or illness, loss of sleep, and seizures can cause confusion. So, what are those guidelines when caring for someone who has confusion? And you can follow right along with me in your book, but do not leave a confused resident alone. Stay calm, provide a quiet environment, speak in a lower tone of voice, speak very clearly and slowly. Always introduce yourself each time that you see your patient or your resident. You may have to remind them often of the location, their name, and even the date. Explain what you are going to do using very simple instructions. And here's the key, you got to be patient. Do not rush the resident. Talk about plans for the day. Routine is very important when you are caring for someone who is confused. And encourage the use of hearing aids and eyeglasses as well. I want to highlight this one. Even though a person may be confused, we still promote self care. And so, what does that mean? We still allow for them to be independent, we allow for them to do as much as they can for themselves. Do not leave cleaning agents or personal care products where the resident can access them. Remember, they do not have the ability to think logically and to think clearly. And so we always think of accidental poisoning and things like that. And any type of observations that are abnormal or is something that is new you have not seen before, you want to report those observations to your nurse. Now let's look at delirium. And like we said with delirium, it is a state of severe confusion that occurs suddenly, but oftentimes delirium is temporary. And so what causes delirium? Well, again, infections can cause delirium, disease, fluid imbalance, poor nutrition. Here are some big ones. Drugs and alcohol can definitely cause that state of delirium. And so here are symptoms of delirium: agitation, anger, depression, irritability, disorientation, oftentimes trouble focusing, problems with speech, changes in sensation and perception, changes in consciousness, and also a decrease in short term memory loss. And so here are just some keys, and you can find this in your book. Some other tips when communicating with a person who is confused or disoriented. It is wise if the nursing assistant keep her voice or his voice low and do not shout. Always watch your nonverbal. You learned that in chapter 2, your nonverbal expressions, your body language, your facial expressions, because again, that aids in understanding. And so they're looking at that. Sometimes they're reading lips, they're reading your body language. And if your body language is coming off aggressive or frustrated or irritated, they kind of feed off of that energy. Use the person's name and speak clearly in simple sentences. Try to reduce distractions in the environment, such as maybe turning down the TV. I used to tell my staff this at times. If residents' rooms are near the nurse's station, keep the noise down, even at the nurse's station, and be gentle and try to decrease those fears. It helps to be gentle also too, because what it does is it reduces some of those expressions or actions. I don't like to call it behaviors, but it kind of helps with reducing some of that agitation when you're speaking in that lower tone of voice. All right, let's look at some new terms here. You can follow along with me in your book. Cognition is the ability to think logically and clearly. Cognitive impairment is loss of the ability to think logically and clearly. Dementia is the serious loss of mental abilities such as thinking, remembering, reasoning, and communicating. And you definitely want to understand that term dementia, as we will be working with many residents who have dementia. And then Alzheimer's disease, I'm going to call it AD for short, is a progressive, incurable disease that causes tangled nerve fibers and protein deposits to form in the brain, which eventually causes dementia. And so remember this: dementia is not a normal part of aging. This is not something that is normal. And so, what are the common causes of dementia? Well, we just talked about AD, which is your Alzheimer's disease, multi-infarct or vascular dementia, which is a series of strokes, causes damage to the brain, Lewy body disease, Parkinson's disease. Very common. You may even see that on some of your test questions. And Huntington's disease also can lead to dementia. It is very hard to diagnose dementia. It's a very complicated process. And so just because someone is confused for a period of time may not mean that they have dementia. They have to go through a process of testing. And so you just see an example here of all of the different imaging and blood tests and things that they have to go through in order to diagnose dementia. And so, Alzheimer's disease, here are some facts about Alzheimer's disease. It's the most common cause of dementia in the elderly. More than 6 million people in the U.S. are living with AD. Women are more likely than men to have AD. The risk does increase with age, but it is not a normal part of aging. AD is very progressive, it's degenerative, so it causes a lot of breakdown, and it's not reversible, so it's irreversible or incurable, what your book has said. We talked about the tangled fibers. We don't know what causes AD. The length of time from the onset, to death can range from 4 to 20 years, and each person will show different symptoms at different times. So again, it takes patience working with someone who has AD. So, nursing assistants should remember these points when caring for someone who has AD. Every person, again, with AD progresses differently, showing different symptoms, and residents should still be encouraged. So, let's begin to look at some of those helpful attitudes for working with residents with AD. Do not take things personally. Remember, it is not you that's causing them to have any type of reaction. It is an expression or behavior based on what their brain is processing at that moment. Be empathetic. We talked about that. Work with the symptoms and behaviors that's noted. It is going to take a team. No one person can work with a group of residents or patients who have dementia. Be aware of the difficulties associated with caregiving. Work with the family members. Remember, the family members are on the care team. They can tell you exactly what needs to happen with those residents. They can tell you what the residents need, all of those things. So definitely work with the family. And also too, remember the goals of the care plan. That's going to be important. Remember those goals. Now, let's get into some of the approaches here and how we communicate with those who have Alzheimer's disease. So, preservation is a term that we see here, which is the repetition of words, phrases, questions, or actions. And so, when communicating with residents who have AD, here are some common approaches. You want to always approach from the front. You don't want to startle them, but you want to gently approach them. Remember, gentle approach. Smile, look happy to see the resident, be friendly. Remember, nonverbal, they feed off of that negative energy. Determine how close the resident wants to be and how close they want you to be to them. You got to remember personal space. Think about yourself. Do you like people in your personal space? How close do you want people to be to you? So kind of, gauge that as you are approaching your resident. Communicate in a calm area with little background noise and distractions. One thing about working with those with AD and dementia is a lot of noise and distractions can cause overstimulation, and overstimulation is what causes them to have behaviors or different actions and expressions. Always identify yourself. Use the resident's name and continue to use the resident's name. Remember, we talked about using those terms of endearment, things like honey, baby, sugar, grandmother, auntie, those types of things. You want to call them by their preferred name unless there's been a change in the care plan where you're able to call them those names. Let me say this. There are times where we may have to call them grandmother because that's something that they're used to. So again, your care plan will tell you what the preferred name is. And remember, always speak slowly using that lower tone of voice. Repeat yourself as often as you need to. That's okay. Using the same words and phrases as often as needed. Use signs, pictures, gestures, or written words to help them understand, but also to help them communicate. Break complex tasks into smaller, simple ones. You can't give them 5 things to do at one time. For example, brush your teeth, get in the shower, put your clothes on. No, you got to break those up in little small tasks for them. Now, if the resident is frightened or anxious, and I'm going to send you some awesome videos that's going to spark a discussion as to how to care for people who are anxious. But again, speak in a low, calm voice, speak in a quiet area. Try to see and hear yourself as residents might. Okay, so again, that approach, describe what you are going to do. Always do that. Use simple words and short sentences and check your body language. That's going to be key. If the resident forgets or shows memory loss, it's okay. Repeat yourself using the same words. If a resident does not understand a word, try a different one. Okay? If they begin to repeat and repeat, asking questions using the same words each time, it is okay. All right? Keep messages simple. Again, break complex tasks into smaller ones. And if the resident has trouble finding words or names, suggest a word that sounds correct and try not to correct the resident. That can be offensive, or correct them saying, you used the incorrect word. Nope, we just coach them maybe to try a different word. Now, if the resident seems not to understand basic instructions or questions, ask resident to repeat your words. Use short words and sentences and allow time to answer. Use the communication methods that are effective. Watch for those nonverbal cues and always observe your body language. And again, signs, pictures, and gestures or written words can also be helpful. Now, if the resident want to say something but they cannot, encourage the resident to maybe point to what it is that they want, or use gestures, or try to act it out for them. Offer comfort with a smile if the resident is upset, or try to distract them. If the resident does not remember how to perform a basic task, again, break each activity into simple ones. And if the resident insists on doing something that is unsafe or not allowed, limit the times you say don't. Instead, try to redirect activities instead. So maybe you'll say, okay, Ms. Jones, let's maybe try this way. Let me give you an example of what I'm talking about. I had a resident one time, I used to work on memory care. And I had a resident one time who she loved to get in other residents' beds. Okay, that was just something that she did. She made everybody's room and their bed her own. Okay, and so one day she got into a resident's bed out of her own wheelchair, wheeled herself up to the bed, got into it, and would not move. She refused to move. And so nurses were getting pretty agitated. We got to get her out of here because we have the other resident that's ready to get in her bed. And so trying to reason with Miss Dorothy is like, no, I'm not getting out of this bed. So I began to think of the things in her care plan that she likes to do. Okay. Instead of putting her in a situation where she's agitated, I began to think about those things that she liked. One thing that she liked is the craziest combination ever: coffee and ice cream. And so now I'm able to redirect her. And I says, Miss Dorothy, I tell you what, I want you to come with me and I want you to have some coffee and ice cream. That's your favorite. Do you want to come with me so we can fix this together? And she said, absolutely. And now we're able to redirect her. So now the situation is no longer unsafe. There's no frustration here, but she gently and kindly moved herself back into the wheelchair so she can go and assist me to get her this snack. So a lot of times we have to always look back at those care plans. We have to think back on the things that has worked before. Remember, it's your approach, it's your actions. Think of those things that worked before, and that's what you use. We're going to talk about in a second validation therapy, and that's kind of getting into their world a little bit so that way we can easily redirect them. If the resident hallucinate or they're paranoid or they begin to accuse you of things, again, don't take it personally. Try to redirect the behavior. Okay, these hallucinations, paranoia, these accusing, this is part of the process with Alzheimer's disease. Now, we've already talked about signs of depression and what clinical depression looks like, but you may work with residents who have this, type of behavior all the time. They're always depressed. So take time one-on-one to ask how they're feeling. This may be the resident that you may have to spend a good 5 to 10 minutes one-on-one. Again, I'm talking about residents who are in special areas such as memory care and dementia. It takes a little bit more time to care for them. Try to involve the resident in activities if possible. A lot of times, instead of me taking them to the activity room, I bring activities to them in their space. Maybe they just want some one-on-one attention. Maybe being in a large group is too overwhelming for them. And so I'll bring a puzzle to their room, or I'll bring, some activities and crafts and things to their room. But remember, any signs of clinical depression, which we talked about in chapter 3, you definitely want to report those signs to the nurse. Now, if the resident repeatedly asks to go home, here comes a little bit of this validation therapy. Now we want the resident to open up and explore that thought about home. And so your book says, ask the resident to tell you what their home was like and how they felt being there. So I'll give you an example. I had a resident many years ago. She would always plant herself in her wheelchair with her bags packed. Okay, she had clothes in a garbage bag and a purse sitting on top of her lap in her wheelchair, sitting at the door, waiting for the next person to open the door so she can exit the building. And so as she's sitting there, every single moment she's screaming, I just want to go home. Can you open this door so that I can go home? And so one day, and she sat right by my office doing this. And so one day I said, I'm going to put this technique, this communication technique to work. I said, Miss Wanda, tell me about your home. And she says, you don't know anything about my home. And I says, absolutely, I don't know anything about your home. That's why I'm asking you. Tell me about your home. And she began to talk about it. Oh, it's hot. It's hot. It's down south. And my mom is there and my sister is there. And I just got to get there. And I says, well, come on. Let's go get ready. Okay. And so now by this time, I'm able to redirect her from the door so people can get in, and then get her back into her room and have a little bit more conversation about her home. Expect these questions to continue and remain patient and gentle with the responses. So you're getting them to open up and explore that thought of that home. Now, you may work with some residents, and we talked about this a bit in chapter 3, but you may work with residents who are verbally abusive. They use bad language. How do I handle this? Well, remember, it is the dementia that's talking. It's not the person. This could have been their personality prior to them even developing dementia. And so this is something that they're used to. They're used to using this bad language all the time. So we try to ignore the language. Remember, do not take it personal. And we do redirect the attention. You got to understand, some people are coming from different backgrounds, different generations. And so there may be the use of bad language. There may be the calling of names. I've even been called racial names, but I had to remember that, the generation that I'm working with, this is something that they were used to. This is probably the last thought that stuck in their mind prior to them developing dementia. So remember, it takes patience, and do not take this thing personal, okay? Now, if the resident has lost most of their verbal skills, that's when we have to have our nonverbal kind of kick in at this point. And so use your nonverbal skills such as touch. Touch displays a message, but you got to remember, everybody does not want to be touched. We talked about that in chapter 3. Consider the culture, consider the background, consider the resident. If this is something that they're okay with. Smiles and laughters are good. Use signs and labels and gestures. Assume people can understand more than they express. And usually they do understand a little more. just unable to put that together in words. So, nursing assistants working with residents with AD should remember these three general principles for providing care. And so now we're getting into our ADLs, but working with those who have Alzheimer's disease. Develop a routine and stick to it. Okay? Develop a routine and stick to it. Promote self care. If your routine is we're going to brush our teeth before breakfast, stick with it. Okay? Always promote self care and take care of yourself, both mentally and physically. Like I said, it takes a lot of patience to work with residents who have Alzheimer's disease. So, definitely, you want to take care of yourself. Now, I have a video that's going to be really helpful and useful when it comes to problems with bathing. And so, I want you all to look at this playlist that I will send you, or it will come after this PowerPoint slide along with a discussion, so that way you can kind of engage in the conversation a little bit about how to take care of someone with AD and assist them with bathing. And so if you're having problems with bathing, schedule bathing when residents is least agitated. That's the first thing. You want to schedule it when they're least agitated. So if the morning works better for them, then that should be the time, all the time, that they actually have their bath. Give residents supplies before bathing to serve as a visual aid. Allow them to pick out what they need. That kind of gets them involved in the process of bathing. Take a walk with the resident down the hall. Stop at the tub or shower room. Have them take a look at it. Sometimes you got to think about the resident. Maybe tub or bath or shower is very intimidating words, but sometimes using words such as a spa or the spa experience may kind of help them feel a little bit more excited to enjoy this experience. Always provide privacy. Make sure the bathroom is well lit and at a comfortable temperature. Let me tell you this. Residents who have Alzheimer's disease, they're going to display all type of behaviors, all type of actions and expressions. And oftentimes they're reacting to the environment. They're reacting to the environment. And so if it's too cold, remember the elderly, they have very thin skin. They're often cold. And so if it's too cold, guess what? You're going to have a behavior. They don't know how to express. Think about a baby who's unable to talk. Someone who is less than a year old, they can express to you that they're cold. They can express to you that they're too hot. They can express to you that they're hungry. But what do? They cry. So this is the same thing with your resident. They may not cry, but they may get agitated. They may get irritated. So you want to make sure that the room is comfortable before they enter. The temperature is comfortable before they enter into the room or to the bathroom or shower room. Bath time can be very intimidating for someone who can't think clearly, for someone who is confused. It could be a very scary experience for them. Be calm, quiet, and keep the process very simple. You want to make sure you have all your supplies, everything there before you begin that process, because leaving out, going back and forth causes agitation. Give your resident a washcloth to hold during the bath time. Get them involved. Even though they may just sit there and hold it, it's okay. Just make them feel like they're getting involved with the experience. Ensure safety by using non-slip mats and tub seats and hand holds. Be flexible about when to bathe. Understand if the resident does not want to bathe. If they're refusing at the moment, it's okay. Remember, I told you, try a different approach at a different time. And be relaxed. Offer encouragement and praise. Ask them the question, are you enjoying this? Let them feel welcome. So here are some other interventions. Let the resident do as much for themselves as possible. And this is a good time. You're going to learn this in chapter 6, but this is a good time for skin observations. Now, when it comes to grooming and dressing, help with grooming. Avoid delays or interruptions. Provide privacy. Show resident the clothing to put on. Always encourage them to pick out their clothes to wear. Lay the clothes in order to be put on. Break tasks down into simple steps and don't rush them. Let me give you some more tips with this. Do not give them a bunch of choices. Let me tell you what I mean by that. If they have a closet full of clothes, you want to narrow that down. Okay, because what happens is you'll end up getting outfits for the winter and it's summertime. And so they'll pick out a coat to wear and it's summertime. And then you'll get frustrated. Or they will get frustrated, I should say, if you tell them, no, it's the summertime. This is not good to wear. Narrow those choices down for them. When I show you the video, you'll understand what I'm talking about. It makes it very easy for them to make choices. And without being so overwhelmed with all of the choices that they may have. If you're having problems with taking them to the bathroom, encourage fluids. Mark the bathroom with signs or pictures. Sometimes we'll put a picture of a toilet on the door because they can't read, or again, they don't have the ability to think clearly, but that picture they may understand. Now that's a bathroom, okay? And so they'll go to the bathroom that way. Make sure there's enough light in the bathroom. Note when resident is incontinent. That is a word that you should know. Incontinent. If you don't know it yet, I want you to go ahead and look it up in the back of the book, because this is a word that we're going to discuss. Check every 30 minutes. Our check and changes. When someone is incontinent, that means they cannot control bowel or bladder. So they're wearing adult briefs, which looks like diapers. They need to be checked quite often. Take resident to the bathroom before bathroom time. Sometimes we got to get them back on that schedule. Observe toilet patterns for 2 or 3 nights if the resident is incontinent during the night. So that way you'll kind of see what their pattern is. Take resident to the bathroom after drinking fluids. Make sure the resident urinates before getting off. Take resident to bathroom before and after meals and before bed. Put lids on trash cans, waste baskets, and other containers. Why? Because your resident will urinate and defecate in them, okay? Because they think that's what that is for. That's why we use pictures and things to try to show them the right areas to go to. And remember, be professional when caring for residents after they have those episodes of incontinence. And then if you have problems with nutrition, encourage nutritious foods, things that they like. Have meals at consistent times each day. Food should look and smell appetizing. You don't want to say things like that does not look good or smell good. I've heard people say that. No, you want them to make them feel like it's appetizing. Make sure there is good lighting. Keep the noise and distraction low. Oftentimes in a lot of our dining rooms, we play music. Music also helps with the dining experience as well. Use simple place settings. Remove items, extra items from the tables. Give simple, clear instructions on how to use certain utensils. A lot of times I will allow the resident to kind of set the table up. Okay, that makes them feel involved and feel special as though they're doing something. So I will allow that. Use special equipment, which we'll talk about in later chapters. Give residents time to eat. Sit with residents. This is what I loved about working in memory care. Oftentimes, I would sit with my residents and eat with them and have a conversation and engage them in conversation. But at the same time, as a CNA, because you are a healthcare provider, you have to observe your resident to make sure that there are no swallowing problems, to make sure that they are eating. So we still have to always be in observation mode. Then, ways to promote health with your residents who have Alzheimer's disease. Prevent infections. How? By following the standard precautions, which we talked about in chapter 2. Observe the resident's physical health and report any potential problems. Help the resident wash their hands frequently. Give careful skin care to prevent pressure ulcers, which we'll talk about in chapter 6. Watch for pain, signs of pain, and report them. And remember to promote mental and emotional health. Maintain that self-esteem and by encouraging independence. Share in enjoyable activities, looking at pictures and reminiscing, which we'll talk about shortly. Okay, now as we are drawing to a close here, here are some terms that you should be familiar with. Sundowning is becoming restless and agitated in the late afternoon, evening, or nighttime. Catastrophic reaction. And so let's look at some of these here individually. You can follow me in your book. But sundowning, let's go back to that. Um, how do we prevent that? So we already said that's when a person gets more agitated at night. And so how do we avoid or help with that? Well, try to avoid stressful situations, limit activities and appointments, play soft music, set a routine. Remember, I told you routine is going to be key. What are catastrophic reactions? Catastrophic reactions is when a person with AD overreacts to something that could be a normal part of your routine or their routine. They begin to overreact. And so again, triggers. It could be too many distractions. They could be overstimulated. They could have a hard time making choices. That's why I said limit the like for example, if they have a lot of clothes in a closet, you want to limit some of those choices so they don't have so much to choose for, which can make them become overwhelmed. Some may have even violent behavior. We've talked about that. Call for help. Don't try to do all this by yourself, but call for help. There's always a trigger as to why someone is having violent behavior. So block blows, never, ever, 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 ever hit back. Step out of the way. Make sure you know, and usually in report or in the care plan, you know your residents who have the potential of becoming violent. You should receive that information before you even start taking care of these residents. And so if they have the potential of being violent, know those triggers. Get somebody in there to go with to help you complete the task you need to complete. What do I do for residents who likes to pace the hallways or to wonder? What causes that? Well, it's restlessness usually, sometimes hunger. Finger foods work really good for those who like to pace and wonder and walk around. Sometimes they could be incontinent. They need to go to the bathroom, so they begin to pace and wonder. It's a form of anxiety. Maybe they're forgetting how or where to sit down. So, what do I do? Again, snacks, finger foods, encourage toileting schedule. Let the resident pace in a safe place. That's okay. We can redirect them. Mark their rooms with signs and pictures. Sometimes we even put up stop signs on certain doors to let them know not to enter into those areas. Um, Hallucinations and delusions. Ignore them if they're harmless. Do not argue. You have some who think they are the president of the United States. I just give them the respect that they want, but I don't argue with them. Depression, we've already talked about signs of clinical depressions and when to report any of those behaviors. We've already talked about preservation or repetitive phrasing. Um, Disruptiveness, again, redirect into a private area. We've already talked about those inappropriate social behaviors. Do not take it personally, stay calm. But anything like that, inappropriate behavior, get to your nurse and get someone else in there with you. Okay? Hoarding and rummaging. I label a lot of things, symbols. We get when it comes to rummaging and hoarding a lot of things, holding on to a lot of things that are years and years and years old. We get family involved with that, okay, so that the family can come and gather some of those things. It can really cause a catastrophic reaction, though, taking some of those things away from them. Sleep disturbances. Make sure resident gets moderate exercise and activity throughout the day. Keep them active. And again, a routine. Sometimes there's nighttime routines to kind of help them sleep. Then you may have a resident who may try to elope. That's right, they may try to escape or leave the facility unsupervised and unnoticed. Now, you do have some facilities, a lot of them, I should say, that those residents who have the potential for eloping, and oftentimes we will know that on admission, but those who have the potential, they may have a special ankle bracelet that will alert others that they are escaping or they're in an unsafe area. But know your residents who have the potential of eloping. That is information in your care plan as well as from your nurse. And know the policy and procedure when it comes to an elopement. You know, how you have to do a head count and things like that. But again, make sure you know the residents who have the potential for eloping. Oftentimes, they'll have pictures of those residents at the nurse's station. And then people with AD may be at higher risk for abuse. Again, it takes a lot of patience, your approach, your attitude, your actions. Sometimes, you know, as caregivers, we get burnt out. So it's no excuse ever to abuse anyone. That's why we said take care of yourself mentally and physically. But if you notice any of these residents ever being abused, you definitely want to alert someone right away when that happens. Know your chain of command when it comes to reporting abuse. We report this to the nurse right away. And last but not least, validating is just giving value to or approving a thing. And so, really, it's just kind of getting into the world of those residents. There are three creative therapies that may be useful in working with residents with Alzheimer's disease. Validation therapy allows residents to believe they live in the past or in imaginary circumstances. And so, I would have patients tell me it is 1932. I allow them to live in that past by getting them to explore that thought. Tell me some things that happened in 1932. You know, oh yeah, this is 1932. Great things happened in that year. Let's talk about some of the things that happened. Just kind of get them to kind of live in the past for a moment. Reminiscent therapy is also good. It encourages residents to remember and to talk about the past. Hopefully, it's good things. Some people like to go back and look at pictures. If you ever notice that in some of your resident rooms, if you've ever visited one, what a typical nursing home room would look like, they have pictures of their families, they have albums, and that's helpful because if a resident is having that moment, they may be sad or they may feel lonely. We'll get the picture book and the album and say, let's look at some of these pictures, and they'll enjoy telling you stories of those that's in those picture albums. And also, activity therapy is good too. One thing we discussed in the beginning chapters is there's an activity director, and their job is to make sure that the facility has activities for the resident. It's beyond just bingo. Okay, these residents are having some really good activities. They have dance night, wine and cheese night, waffle Wednesdays. You know, they actually do have games they play. They take trips. They do all types of things. So activity therapy is really good. It's beyond just arts and crafts. They do many things to help keep them engaged, to prevent boredom, but also to promote that self-esteem. And so music therapy has been used successfully with people who have AD. Music is a form of sensory stimulation. Remember, I told you we play music sometimes, music of their day, not our day, but their day. We play that during times when they are, you know, in the dining room, when they're eating. I've seen some CNAs, you know, have their phones on, you know, music. We're not supposed to have the phones in, you know, patient care areas, but there are times it's allowed to where they'll play music when they're bathing and things like that, just to kind of keep them calm. Hearing familiar songs may cause a positive response in people with dementia. Just think about what music does to you. Music therapy may be utilized to accomplish specific goals, such as managing stress, improving mood, and enhancing cognition. So the nursing assistant can help by observing the resident's response and playing the music that they enjoy. So this concludes today our discussion on confusion, Alzheimer's, and dementia. Remember, takes a special person to have patience, compassion, sympathy, and empathy to work with those who are confused, who has dementia or Alzheimer's disease. And remember, it's all about your attitude, your approach, and your actions when you're caring for these residents. And so I will see you in our next chapter, which will be chapter 6. We hope you enjoyed this. Remember, take the time to go back, listen to this lecture if you need to. There's going to be a series of videos that will follow this lecture, which will spark a discussion to help validate what we've talked about. Take good notes, highlight. If there's any terms that I mentioned to you that said you need to know, please make sure you go back and learn those terms.